So with that, I'm going to try and cover. This is a complicated topic, but we'll have a look at the insights on Impella and ECMO for cardiogenic shock. What have we learned from danger shock and ECLS shock? I have no relevant disclosures. So we all know that in the ACS 2023 guidelines, it says that in patients with ACS and severe refractory cardiogenic shock, short-term mechanical circulatory support may be considered, and there was 2B and C. And then the routine use of an IBP in ACS patients and without mechanic is not recommended, so class 3. Moving on to 2025, the recommendations from the United States ACS update went up to 2A, and the statement now has changed. In selected patients with STEMI and severe or refractory cardiogenic shock, insertion of an Impella, I'm just going to use the word, is reasonable to reduce death. And then the second one is in patients with mechanical complications of ACS, short-term MCS devices are reasonable for hemodynamic stabilization of the bridge. So you notice that the ECMO implication has disappeared. And we will review together, for those of you who are not familiar with the literature, why that is. So there were two papers from the 2023 ESC guidelines that were published that changed the field essentially. The first was ECLS shock, published in the New England Journal in 2023, and the second was danger shock, published in the New England Journal in 2024. So let's learn about these two studies and what the features were. So ECLS shock was a European randomized multi-center shock. They look at acute myocardial infarction complicated by cardiogenic shock with planned early revascularization, and then they randomized patients to early ECLS or control. They had 420 patients. 2/3 of the patients were STEMI. Importantly, 78% of the patients in ECLS shock were resuscitated from cardiac arrest. 97% was PCI, so this is really a PCI study. In the ECLS arm, there was 15% control crossover to the ECMO, so this is a strategy trial, right, not an intention to treat analysis. And then the timing as well is interesting. In 1/4 of the patients, they put in the ECLS before the revascularization, in 1/4 during the PCI, and then in half of the patients after the revascularization. And that may actually have implications in the effect it has on the patients. The median ECLS use was short, 2.7 days. And then there were other devices added, like 8% overall. They added another device like an Impella or an IBP. And then in 17% specifically in the control group. So it's not a very clean study overall. At 30 days, the trial was completely negative. There was no difference in outcome. At 1 year, there was no difference in MACE outcome. But major bleeding was much higher, as you would expect, at 23%, and most of it was vascular complications. So then we look at the danger shock trial. This was a European randomized multi-center trial as well. They looked at STEMI and shock with planned emergent revascularization. The last study was 2/3 STEMI and the rest were non-STEMI. This one was just STEMI. And then they excluded resuscitation patients who were comatose. So they learned something from the design of ECLS. So they left out the people who were not clearly functional, and they left out patients with RV failure, which is also another important point. And only 20% were overall resuscitated but non-comatose. And this is once again really a PCI trial, 97% of PCI. In the treatment arm, 95% of patients got the Impella, 2% in the control group. And here, 85% of those patients had the Impella before the PCI, compared to what we saw with ECLS. And then in 16% of the Impella beginning group, they escalated the treatment. So 1/5 of those patients ended up still getting an ECMO, still getting an LVAD, or escalating to Impella 5.0. The treatment duration is about the same, 2.5 days. Mortality at 180 days, so at 6 months, was 46% in the treatment group and 59% in the control group. So about a 1 in 10 reduction. And then they had some sort of safety event in 24% of the patients versus 6.2%. So now that we've seen them, we can compare the two. ECLS shock was larger, slightly. The inclusion criteria was AMI complicated by cardiogenic shock and planned early revascularization, while on danger shock, it says STEMI patients with cardiogenic shock. The most important thing was the exclusion of comatose cardiac arrest patients in danger shock. And then if you look at SKY, CDE, they're about the same, right? Or you could make an argument, that, they're about the same, 56% C, and then the D and E's were like 29, etc. The EF and admissions was about the same. The admission lactate, because now that this concept that SKY is trying to push of door to lactate time is higher in the ECLS group versus in the Impella group. And then ROSC, 78% on ECLS, cardiac arrest, and then 22% in danger. And then once again, the MCS, when it was started, was different. Now, there was a paper that went then and looked at within the ECLS group, from all the VA ECMO studies. They took 4 trials and they looked at the patients that met the criteria for danger instead. And then they looked at those patients, right, STEMI only, low likelihood brain injury. And at 6 months, you start to see this trend of non-significantly lower mortality at 45% versus 51%. Still higher bleeding, still higher vascular complications, but this is an underpowered study at 202 patients, right, that fit the criteria. So maybe if they were to repeat ECLS shock 2 with the patients that they enroll in danger in a larger number, it could possibly actually end up being positive again, right? Maybe they were too ambitious. So when you look at the patients who had bailout or escalated MCS and ECLS shock, right, what was the difference? Mortality was not significantly higher with bailout or escalated MCS. Replacement dialysis is higher in those patients, and moderate or severe bleeding was similar. So despite the fact that you added more devices, the patients really didn't do that much better. So you're really, and that's probably because it's such a sick cohort to begin with. Now, there was also an interesting sub-study that was just published about culprit only versus multi-vessel PCI. As we know, the current recommendation in shock is to only do the culprit. But when you look at the culprit versus the multi-vessel PCI in the danger shock group, they found that immediate multi-vessel PCI had a 60% lower odds of mortality compared to culprit-only PCI in this cohort of patients. And when you look at those patients, you say maybe they were different, but the clinical characteristics and median pre-PCI syntax score, there was no difference in both groups. So there's been an argument that maybe, as we saw earlier, because you have MCS, you tend to do a better job. You spend more time post-dilating, you spend more time calcium modifying, you spend more time with intracoronary imaging, etc. So maybe that's what it is. Maybe the PCI is better. So what is the risk of renal replacement therapy with Impella from danger shock? Remember that there was a very high rate of safety events. Most of those safety events in danger shock was actually the need for dialysis. So dialysis was used in 47% of Impella patients and 27% of controls within 30 days. So if you're going to put an Impella in this setting, you better be also prepared to do dialysis. But still, regardless of the need for dialysis, Impella was still associated with improved mortality. The predictors were shock severity, high baseline creatinine, and then suction events, and then higher pump speeds and longer support. So the hemolysis is really causing trouble here. So if you're going to be putting Impellas in, you need to know how to avoid hemolysis and manage hemolysis. This is another very important slide. I think this is actually the most important slide from the Impella danger shock. So what is the effect of age with Impella from danger shock? Okay. So despite a lack of difference in clinical characteristics across age quartiles, the mortality increases steadily with age. 31% in the lowest quartile, 47%, 61%, 73% in the oldest quartile, that's age 77 and above. So even though we keep talking about Impella being awesome, in the United States, many of our Impella shock patients are old people. Still, perhaps that is still not reasonable, right? You could argue futility to put in an Impella with 77% mortality. What are the hemodynamic and metabolic effects from Impella in danger shock? You can see that the use of vasopressors and inotropes decreases compared to standard of care. You can see that the mean arterial blood pressure improves quickly, and the lactate normalization is achieved faster when you use Impella. So what is the future for VA ECMO in ACS overall, not in cardiac arrest, right? We're going to hear a very exciting talk after this in cardiac arrest. The big questions that are being asked is that should we vent ECMO patients in standard? Should we put in an IBP, and should we put in an Impella? So there's the ANCHOR study, which is the assessment of ECMO in the AMI cardiogenic shock, which is VA ECMO and IBP, and the results are due, actually should be out soon, October 2025. Then there's the VA ECMO unload ECMO, which is ECMO plus Impella versus ECMO only, and that's due out soon. So we should be seeing a lot of this stuff coming out soon. And then there's the reverse study, Impella with a VA ECMO for cardiogenic. So these are the next question that's being asked right now. So to conclude, select STEMI patients with cardiogenic shock in healthcare systems that can afford it. I think that's a very important statement, that can afford it. Impella use is reasonable to improve mortality. Your number needed to treat is 7.7 at 180 days. Routine ECMO in ACS patients with shock is not recommended, but it may still be useful in the right sub-selected patients. Elderly patients with Impella, there's far less benefit, and the same is true actually for ECMO. Dialysis is higher with Impella, but the survival benefit is still preserved. Impella use clearly reduces vasopressor and inotrope use, maintaining hemodynamic stability and achieving faster lactate normalization. And so this door to lactate concept that's being proposed by Sky is a space that we should watch, and it's a way that we should think about our shock patients as well. And soon we should have the results of randomized trials of routine addition of LV venting to ECMO in ACS shock. Thank you.